Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geeky. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Hello, and welcome back to the Docs of Vernon interview series. Today I have the honor and privilege, and honestly, I'm so excited to have you here. I am interviewing Dr. Johann Schreve. He is an MB-CHB CCFP trained physician working here in Vernon. He also has his diploma in emergency care, and he also does GP oncology, which we're going to talk a little bit about. He also has a passion for quality improvement and processing data technology that actually helps us provide better care. And outside of medicine, he is a loving, wonderful husband to his very beautiful wife and 4 children, 2 dogs, don't forget the dogs. And he loves pickleball, playing guitar, mountain biking, and golfing. Of course, you have to love that if you live in Vernon. And today is going to be a very exciting interview because there are 5 topics I'm going to try and cram in 10 minutes. No, I'm just kidding. In all seriousness, welcome and thank you for being here.
Thank you for inviting me.
Yeah. So something that's really cool about Dr. Schreve is that he does GP oncology. He's also one of our hospitalists working full-time. Part-time. Okay. He also does a lot of work with the PQI quality improvement projects, which are happening usually twice a year.
1 cohort a year, but I am on the regional council. So it's the Alum Regional Council. So when you're done with the cohort, they put this council together that is basically advocating for how quality improvement should go across the region. So I'm sitting on that, and that is, very exciting for me because I think we're moving in the right direction when it comes to quality improvement, but we still have a long way to go.
And can you just share with us a little bit more about the quality improvement? Like, how long ago did this start? Was this something that people sort of started to take initiative on and then there became funding for the research, or what exactly is it?
It's basically a program that was introduced by Docs of BC. Basically, all the health authorities ask for physicians that are interested in quality improvement, and they have these different cohorts. So every year they'll take in a cohort and you learn everything about quality improvement, which is determining if there's a problem, the methodology behind fixing it, stakeholder engagement, leadership, and then collecting the data or utilizing the data to decide if you made a difference by implementing a solution. That takes about a year, and during this time you do your project. For my year, I was part of cohort 3, which was now 4 years ago. 5 years ago? 5 years ago, actually.
Awesome.
Time flies.
It does.
So I was part of that, and part of my project was about documentation. So we do these notes on the computer, and the goal behind our project was to figure out if we can standardize that documentation so that handovers are easier, but that patient care in the process is improved. 5 years later, I can say that there's still some that's doing what we did.
Me being one of them, I will say, honestly.
And then there's a few that is kind of doing their own thing. But in the end of the day, what you learn through these cohorts is how to identify your strengths and weaknesses when it comes to dealing with conflict or in leadership. Mm-hmm. We learn that there's a lot of different personalities around a table, and that you have to find, there might be people that will jump on the opportunity to change, and then there will be people that will never change. And we call them late adopters for a reason. And I've learned a lot through that process. And part of the other part of it is you learn to, or you get to know a lot of the other passionate people in the health authority that's also interested in this kind of work.
And what I'm actually hearing is, the quality improvement, it has the leadership component, it has the medical improvement component, it has the research component, and then overall, you notice that over time, these pieces that you've already done are now being implemented over the years, which is,
Correct.
if anybody knows this, is a very slow process in medicine. So
extremely slow. And then if you show a tremendous amount of improvement, some of those projects have actually spread to other parts of British Columbia and even other provinces. So the work is there. We know that the healthcare system, which we'll probably talk a little bit about later, needs a bit of like a change. And from a quality perspective, I think we need to have quality docs or a culture change to actually make those changes on the ground and participate in working towards a system that works for every Canadian.
The other thing I wanted to ask you about was really your position as a hospitalist, because I have seen over the years quite a change in maybe not just acuity, complexity, amount of patients in hospital, staying longer, maybe not staying long enough. And how have you really noticed that role evolve? Because you've been part of this for a while.
Yeah, I think and I joke about it, when I graduated 15 years ago. So, I break it into 5-year pieces, right? Smart. Which is easier to digest. Right?
Yes.
When you look at 5-year pieces, when we were done with medicine, when you were admitted, it was kind of one thing, like, and I joke about it, but it's like you have pneumonia, we treat you with antibiotics, or you need intubation, go to ICU, and then you can go home because that was the reason, right?
That's right.
But in terms of complexity, I think a lot of our patients have a lot of comorbidities. So what we call comorbidities is a lot of medical problems that kind of accumulates over years. And when a disease like pneumonia comes about, there's always something else.
Yes.
We know that our patients have gotten older, and when you get older, the immune system is a little frail. You have a little bit more comorbidities to the heart, the lungs, or the kidneys might not be working that well. So typically, the admission that needs to take about 3 days or 5 days turns into a week or longer. And I think you can kind of you've seen that too,
yeah.
Right? There's a lot of things in between this because of mobility. And then there's also care at home. What does supports look like? So as a hospitalist, which is basically a family doctor trained, you look at the person as biopsychosocial. And we know that you can't just let somebody go home if they don't have support, because then they'll just come back, right?
That's right.
So a big part of that has changed in the last 5 years. We have teams now in the hospital that actually helps us do discharge planning, which helps a lot because we've also seen that we call it a patient per provider ratio, and our patient per provider ratio has gone up significantly, and as a result, the doctor is focusing more on the medical side of things. But what we call a transition liaison is somebody that will do the discharge piece and will touch base with family, look at financials, etc. Then we have excellent social workers. We have OT and PT that looks at mobility. So the entire admission is more complex. But the reason why I do acute care is because it's often the time that you can get a diagnosis, you know?
To your point, noticing that we don't have enough family physicians in the community,
Yes.
People are often coming into the hospital way more sick than they ever would have been because the gate wasn't there to stop the first thing.
Correct.
Recently, there's been a lot of changes in Vernon, in the hospitalist group, in the community, and the hours have increased. Now, normally it would be a 9-hour day. The benefit of being a hospitalist is that you know you're done with your patient. At the end of the day, you know they're safe, they're in hospital, nurses, there's an on-call doc for the night. But there's been so much changes that we've noticed such a strain on the system in a different way than maybe before.
So taking that predicted workload, we're sitting about 12 to 14 hours a day. But there's also other factors that we have to, like, for example, documentation.
Yes.
And the EMR or
Yes.
the EHR. our EMRs are very good in keeping information, but they're really bad at finding it.
Yes.
So, because,
Best way.
and that is why I became interested in technology, and I think that's where artificial intelligence might be the answer to, because patients have very complex histories with a lot of investigations, but as a human being, you can only kind of look at some of those things all the time.
Yes.
But the artificial intelligence can bring it out for you.
Yes.
If that makes sense.
Quickly.
Right? Quickly, exactly. I think the issue for us is that there's so many moving pieces that we have to, in a way, triage.
Yes.
And I don't know if if you have an emergency doc who spoke on your series, but we have a CTAS triage system where you get a color, and that color basically determines how acute and that sometimes mean that you will probably not be there for the total amount of time, but the time that you spend figuring out and organizing the care of the patient is factored into it. So when when you're admitted to hospital, think about everyone in that who sees you as your care team. Mm-hmm. And there is one guy sitting there making sure everything runs smoothly, but sometimes you might not see them, or they might not reach out directly to your family as we would have done in an environment where we were having normal hours and time to do it all.
Yeah. And I think that was a really good point, because what I've noticed is you might be texting with nurses, or not really with nurses, but like the lead of how do you really describe that? It's called a PCC, but it's somebody who sort of supports the whole team and their moving parts in the hospital. And often we'll be in contact, like say we had to go see a patient in emerge or somebody on another unit. We'll still be getting messages about various patients through the blog about different things.
Yes.
And we might be dealing with a loved one all day, 12 hours, the same person, but we've only seen them for 36 minutes.
Exactly. And that's a good point, because I think that people often link the care they get with how much that they see the doctor, right? Mm-hmm. And I, like when I started medicine, like I mentioned, the 15 years, there was time to see those patients if you worked in our size hospital.
Yes.
Right? If you're in tertiary, it's a little bit more volume, but our volumes have grown significantly, but our care team in terms of our nurses and physicians are more or less the same.
Yeah.
That 36 minutes, actually 3 hours.
Yes.
Right? Phoning specialists, making sure that investigations are done, checking those investigations.
Yes.
Charting, and maybe communicating with family. So it is not ideal. Mm-hmm. I think you feel the same way.
Yeah.
But it's the best we can do.
Yeah.
Right? And I think I've never seen a doctor not give his best or
True.
her best.
How easy the healthcare system is supposed to look on paper. Free healthcare, access to an ER 24/7, and how completely opposite that really seems to be.
Yeah. I'm not from Canada, obviously. Yeah, so I come from South Africa, and I mean, it's not as complex as here. Physicians, especially in leadership positions, couldn't navigate the system very well. But if they can navigate it, it brings up a good question: why is it so complex? So what I've learned through my journey in Navigate is that the system cannot be deciphered. It is like the Vinci Code, in a way.
What do you kind of mean? Because it's a great description. I think I would describe the healthcare system as that, honestly.
Well, yeah, so the Da Vinci Code is a way where clues are left, but there's something behind every clue, right?
Okay. Like there's a reason that something was done a certain way,
correct, yeah,
which just might not make sense for that situation.
Correct. And we don't know that because it's now sort of
6 people later.
Exactly.
Okay.
Exactly. So the people who developed this, who thought it was a great idea, probably had an amazing vision.
Yeah.
But we haven't really adopted or adapted as time went on, or maybe the message didn't come through. So it's a really good way to put it. Is that I think that the healthcare system is just not it's not maturing with what is needed of it, and it's staying complex as a result.
Yes.
Right?
Yes.
Hopefully in the future, and not too distant future, we can change that. And we
Yes.
can decipher these codes.
Maybe AI can. Let's say from a patient perspective, how do we even navigate the system then if there's so much complexity that even healthcare providers don't understand?
Let's take an example to answer your question. I have a 9-year-old mother with dementia.
Okay.
And it's been tough because we don't want to get any care into the house, right? And my brothers, who's amazing caregivers, helps to take care of my mother. But at some point in time, there's burnout.
Yes.
And mom falls down in the middle of the night, and she is brought into the emergency room more confused than usual. The emergency doctor does all the workup and finds that she's got a urinary tract infection. And she gets admitted. Within a day or two, she's getting a little better, but the dementia takes a bit of time to clear. But the family comes to us and say that they can no longer take care of mom. So we asked them if they've been connected with the resources in community. And they said no.
Okay.
And we asked why not, and said, well, we were coping, but we cannot cope any longer. So what happened with this case is that in the system that's complex, because there's no interaction with the health authority and care, the patient cannot be placed from hospital for a higher level of care.
Yeah, there's no, now she's in the unknown zone.
Now the unknown zone is a challenge because there's a waiting list for these patients which have grown in numbers. What will happen is that we will have to put home supports in, and she will have to go back to her usual living situation, then be placed from the community. So I would encourage everyone, if you're not in the healthcare and you are looking after your elderly father, grandfather, anyone, to connect with the supports in the community, as it helps to flag certain things.
Yes.
And it helps the system to recognize that more help might be needed in the future.
I would think, I'm going to cope as long as I can until I absolutely can't. And then we'll see when that moment is. And then I'm sure when I bring her to the hospital, it'll be okay.
Yeah.
She'll be taken care of. But it doesn't work like that. So now you're already at your point of no return.
Yeah.
And the system isn't there to support, just
To help.
not by any fault of really the system. It's just the way it's designed and the way that we need to make these changes.
Exactly. That is an example, but it happens more than we want it to happen. But I don't think the system thought that they would see these many elderly people that did so well for a very long time.
It's true.
Right?
People are living longer.
They are living longer.
With more quality.
With more quality. So, but the quality changes quite fast when something happens. For that reason, I think Nikki spoke about it, but is the Advanced Care Planning booklet that's available on Interior Health. It's a really good booklet that allows families to have honest discussions and start planning. It's like setting up a will or setting up your substitute decision maker. If you can plan and have things in place, then I think it will be a much easier navigation. So I do encourage everybody who you can start even when you're 50 to have that booklet and think about things like you would for your will, or you would look at any other document for your future planning.
That's right. It's very interesting. I see this a lot in my elderly patients, and I constantly have to ask myself as a provider, is this what this person would really want? Should I really be doing all of this? Or am I stuck between a rock and a hard place because I can't live with myself? I don't think the family can live with themselves if we don't at least try or look at something or try to land on, any sort of decision. And so sometimes we end up doing way more than maybe was actually what the person would have wanted. And so having that conversation at 50 when you're clear-minded and you're well and active might be a little bit different than when you're, no longer able to take care of yourself.
Exactly.